Alright, hi guys, very good evening to all of you and welcome to today's YouTube session where we'll be discussing some of the important images in pharmacology. Now, as you all are aware that in pharma we don't have much of images, but some of the important graphs, teratogenic effect, different ADRs that are highly expected in the examination, we can discuss it at any point of time. Okay. Alright, so let's get started with our today's session. But before that, I need a quick confirmation from you if the audio and video both are fine. Please just give a quick confirmation here. All the students, those who are live right now, you can give me a quick confirmation through the comment section here. For all the students, those who are new here, you can communicate directly in the live chat option here. If everything is fine, then we can start immediately. Now, before I start, a couple of announcements that we are having about the upcoming batches, right? And the reason why you should choose the platform that has been mentioned, like multiple success stories are coming around, and all the top educators are on the platform. You have live plus recorded session as well. Everything is coming on the platform. Plus, at the same time, you can avail the benefit of Iconic subscription as well, which will be Unacademy and Prep Ladder both. All right, and these are the some of the subscription that you have, and the cost for the plus and for the Iconic subscription that you can utilize. And for availing additional benefit in any one of them, you can use the code Pharma10, right? Pharma10 will be your code to avail some additional benefit in any of these courses. All right. And these are some success stories about the student, those who have cleared the recent FMGE examination. A lot of students are above 200 here, and the final booster batch that has started Feb 1, and it will be a 1 month. You guys can avail it. For all those who are going to join it now, you can have the benefit of the recorded one. You can watch out the recorded session that we have here. All right, so after this short introduction about the new value offerings on the platform, it's time for us to start already. And all the students those are having problem with the quality, you can choose the higher quality, like 480 or 720, depending on the requirement, because I'm getting some personal messages as well. So sorry, during the live session I won't be able to reply to your personal messages, but during the chat, I mean YouTube chat wale jo hai, that I can definitely reply, because I'm using my phone to check your all the responses that we are getting here. I hope all of you guys are ready, and can we start? As I said, pharma mein we don't have much of images, but important ADRs, teratogenic effect, graphs, these are the common area from where questions are very frequently asked. Let us see the very first question. An anti-diabetic agent that can cause the shown condition. I hope all the students can check this out already, and you can see in this image that there are certain changes that has been done on the fundoscopy. You can see on these areas. All right, so what is this area called, and which of the following anti-diabetic drug can cause this? Can you guys tell me quickly? Audio problem thoda sa. Doctor, there is no connectivity issue from my side, but if there is audio problem with anyone else also, you guys can message quickly. Anyone else who is having this problem of the audio? Any other student who is having problem with the audio? Hi guys, please reply to the questions that is being asked. Otherwise we won't be able to know that we are on the same page. Okay. Now this is a case that you can see will be a case of macular edema. Do remember, macular edema, we also call it as a cystoid macular edema, CME that we say. It is a common complication post cataract surgery, but an anti-diabetic drug that is causing here will be, right? Is it glipizide? Glipizide is one of the second generation sulfonylureas. Glipizide is second generation sulfonylureas. Metformin, it is one of the AMP kinase agonist. A-carbose, voglibose, miglitol. What are these? A-carbose, voglibose, miglitol. They are the alpha glucosidase inhibitor. Pioglitazone is the drug that happens to be one of the PPAR alpha. Now there are two things that you are revising here. Pioglitazone is PPAR gamma agonist. One thing that you revised is which drug can cause cystoid macular edema. So cystoid macular edema can be associated with this one, that is PPAR gamma agonist. Do remember PPAR gamma agonists are having some of the important side effects that you should know at all times. In addition to nausea and vomiting, which is a universal kind of side effect, they can cause sodium and water retention. Because of sodium and water retention, remember, there can be weight gain as well. Now this weight gain is different from the weight gain that is caused by sulfonylurias. Okay. Apart from that, they can even lead to other problems like your cystoid macular edema. And pioglitazone as a drug that we have, they also increase the risk of bladder cancer. Risk of bladder cancer mainly associated with your pioglitazone. Under PPAR gamma agonist, we had other drugs as well, like rosiglitazone, troglitazone. We are not using them because of the toxicity. Like rosiglitazone is cardiotoxic in nature, and troglitazone is hepatotoxic in nature. So I hope all of you guys are okay here, and you got the answer to your question that this is a macular edema case, and the anti-diabetic that can cause here will be your pioglitazone or PPAR gamma agonist. Okay. Other PPAR gamma agonists can also cause this macular edema. Okay. Now these are the graphs. So I'll be having 3-4 graphs, and I want each one of you to master this. I am pretty sure all of you guys are already aware about this, but still just to make sure that you guys are on the right page and we are understanding the same. Go ahead please. True statement about the shown image. A is least potent and most effective. You have to reply to these questions in the comment section. A is more potent than B and more effective than C. B is more potent than C and A. C is least potent and more effective than A. C is least potent and more effective than A. Now whenever we talk about the order of potency, we are having always potency goes in this order. P, D, L. Potency में always we will be looking at the dose line, है ना, dose line पे ध्यान देना है, and left वाला will be the most potent one, है ना. So potency में power को देखना है, right? Lowest dose that can cause the effect. Lowest dose that can produce the effect. So we are actually looking at the dose line here. We are looking actually at the dose line here. And if you are going to look at the order, if you're going to look at the order here, the order of the potency will be A followed by B followed by C. We never look at the height. Potency में height को कभी नहीं देखना है. Always and always look at the left to right. For example, this is the graph. सबसे left में ये है, that is number 1. This is number 2 and this is number 3. As you move from left to right, potency will decrease. Next will be your efficacy. Efficacy, and what do I say about efficacy? It is the maximal response regardless of dose. Maximal response regardless of dose. Now do you guys know that maximal response regardless of dose that we have, this is the exactly what we want during the clinical scenarios, right? So efficacy, it is the one that is clinically more important. It is the efficacy which is clinically more important. I hope it is making sense to all of you guys. Now efficacy, I want you to just remember Eiffel Tower, right? I want you to remember by Eiffel Tower. That Eiffel Tower, why was Eiffel Tower famous, and why is it famous? Because of its height, right? So efficacy में you always look at the height. जो जितना बड़ा वो उतना ज़्यादा efficacious. What will you look in the efficacy? Look at the height. Now if you look closely, the height of your B and C is almost same. B or C almost same है. That means B is equi-efficacious to C. So here efficacy will be B is equal to C and least efficacious will be A. Right? Always remember, जिसका height छोटा है they will be less efficacious, जिसका height बड़ा है they will be more efficacious. I hope it is making sense to all of you. Please let me know if all of you guys have got this one, and definitely they also ask you one more question about audio problem. What kind of audio problem you are having, doctor? What kind of audio problem are you facing? Dr. Lakshmi Krishnan, can you reply to this? Okay. Now, in addition to whatever I have discussed with all of you guys, let me show you one more thing, which is always very favorite for the examiner. And this will be again on the same potency efficacy may. On the basis of the graph, you have to find out about the type of inhibition. For example, if you are going to get a graph that will be, let's say, this will be like this, and this is going to be the log dose, and this will be the response or the effect that we have. Whenever there is two graph that is having almost a similar efficacy, and the graph is shifted to more towards the right side, and if the examiner is going to ask you what kind of effect is being shown here, so whenever the graph is shifting towards the right side, always remember this is mainly seen in the competitive inhibitor. This is mainly seen in the competitive inhibitor. All right, now just to make sure that you guys have got this one, the competitive inhibitor, why the graph is shifting towards the right side? Why? Because we need a higher dose. We need a higher dose to perform the same kind of effect, or to achieve the same kind of effect, we need a higher dose, right? So whenever you take a higher dose, what will happen? Whenever you take the high dose, the potency will actually decrease, but what will happen to the graph? The graph will be shifted more towards the right side. Pretty simple concept. When you need a higher dose, potency will always and always decrease. Another one that I can show you, that let us say you have achieved this response. ठीक है, आपको ये response मिला है ना, where one is coming down, and if they are asking what kind of inhibition is being seen here, so you can simply say this will be a non-competitive inhibitor. So non-competitive inhibitor will not compete for same site. They will not compete for same site. So no matter how much dose you increase, they will never achieve the similar kind of response or the actual response that has been seen by the previous drug. Okay, therefore always remember a very important point here, that in a non-competitive inhibitor, actually what is going to be affected will be your efficacy, and efficacy will be decreased. So non-competitive में the height of the graph will come नीचे, non-competitive, and for non-competitive and for the height of the graph will come नीचे, efficacy will be decreased. And what will happen to the graph? Where will the graph go? The graph will be shifted more towards the downside. So ये एक क्वेश्चन है जो बार बार आता है, right? For anyone who is having problem, try to change, go to the setting. On the top right corner of your screen, there will be a setting button, and choose the quality to 480 or 720. Okay? So competitive, non-competitive, I hope you guys will be able to mark. Now, can I ask a very simple question here from the basis, on the basis of your biochem, that in the competitive inhibitor, what is happening to the Vmax? Vmax is achieved, right? Vmax is going to be same, but what is happening to the Km? Km is increased. See, Km is increased. And what happens to the Vmax and Km here in the non-competitive? So remember, Vmax is going to be decreased here, but Km will remain same. Km will remain same. ठीक है, तो ये भी एक concept है. I hope all of you guys have got this. At any point of time, if you need more clarification to this, right, you guys are always welcome. Okay. Now there are two drugs here. I want you to be very, very careful on this one. There are two drugs, drug number A, drug number B, C and D. A को हम बोलते हैं agonist, competitive inhibitor. B is B, allosteric inhibitor is C, allosteric activator is C, allosteric inhibitor is D. Examiner is asking which kind of graph will be obtained. So from this graph, A, B, C, D, 4 graphs are seen. Which type of graph will be seen? Right? If drug A and B competes for the receptor. So ये ड्रग है A and ये ड्रग है B. अगर ये दोनों ही compete करेंगे तो which type of graph will be seen? Now let me give you a hint here out of this one. This is the Vmax. ये इसका Vmax line है. ठीक है, ये इसका Vmax line है. And A वाला is due to some additional changes. A वाला is due to additional changes. चलिए, tell me. which kind of graph will be seen? So we are having 4 graph here, graph number A, graph number B, graph number C and D. 4 lines are there in the graph. So if A and B are going to compete with the same receptor, A and B, what will you see? A, B, C, D. All of you please try. Some of you are asking, XYZ is asking Km. Km is the concentration which can bring half of the Vmax. Or to bring half of the Vmax, what is the concentration of substrate that we need? एक ऐसा concentration जो Vmax maximum है, Vmax की half तक पहुंचा दे, उसको बोलते हैं Km. XYZ. Okay. Now what we can see here, very very simple question, agonist and competitive inhibitor. So I can make it more simpler for all of you guys, that we are having 2 drugs and both of them will be competing for the same site. If both of them are going to compete for the same site, they both have high affinity. मान लीजिए आपका ligand हो गया, ये आपका drug हो गया. They both will have high affinity. They are going to compete with each other. And whenever there is a competition, what happens to the graph? Graph will be shifting more towards the right side. And if you increase the substrate concentration, or let's say drug concentration on the high side, if you increase the drug or the substrate, the outcome will be Vmax can be achieved. Vmax can be achieved. But only thing that happens is graph will be shifted more towards the right. Graph will be shifted more towards the right side. I hope it is making sense to all of you guys. So here A and B is going to compete for the same site, and when you increase the dose at the high dose, you are going to achieve the same Vmax that I have given you already. So the answer to this question will be C. When A and B are going to compete with each other, you will be getting C wala graph. Right now, what about B wala graph? When will you see B wala graph? Right? B wala graph that we have will be seen if only agonist is going to bind. If only agonist binds. Agonist means drug number A. If agonist binds with the receptor, ठीक है? If only agonist bind with the receptor. Now A जो सबसे highest है, even it is going beyond Vmax. This is if only allosteric activator binds, right? So A वाला क्या होगा? It is more than the Vmax. So A will be achieved if only allosteric activator is going to work. Allosteric activator is working. Allosteric activator is working with the agonist. Agonist तो है और साथ में उसको कोई allosterically activate भी कर रहा है, sensitivity को बढ़ा रहा है. Okay. And graph number D नीचे आ रहा है. So that is non-competitive inhibitor. So this is mainly if only allosteric inhibitor, जिसको लिखा है ना allosteric inhibitor, अगर उसको दिया तो if only allosteric inhibitor is given. If only allosteric inhibitor is given, right? I hope it is making sense to all of you, right? And this type of question again, ये ग्राफ वाले जो क्वेश्चन है आपके एग्जाम में किसी भी समय कभी भी आ सकते हैं, तो be ready with this kind of questions. Is it clear to all of you guys that why C is the correct answer and others are not? What is happening in the entire thing? The basic concept remains the same. All cool here? All cool? All of you please give the response. If we are fine here, then we can proceed with the next one. In the shown image, the line marked with X. The line marked with X. तो ये हमारा X है. X के पास जो line है, this is actually representing what? Potency, agonistic action, antagonistic action, inverse agonistic action. So what does it show? Pretty simple question. I think थोड़ा लैग है, आप लोग का रिप्लाई थोड़ा लेट आ रहा है. सर वंस अगेन अबाउट एलोस्टेरिक. देखिए एलोस्टेरिक एक्टिवेटर क्या होता है? दे बूस्ट द एक्टिविटी, दे इंक्रीज द सेंसिटिविटी, दे डोंट compete for the same site, they act at a different site. जैसे कि this allosteric activator that we have, it will be binding mainly at this site. If you look at the graph, it is going to bind at a different site. and after binding at the different site, they can actually increase the sensitivity of these receptors. They can increase the sensitivity of these receptors. So the overall outcome will be more than what was expected. तो अगर मैं सिंपली पूछता हूँ कि जी ग्राफ ए कैसे आ सकता है जबकि वी मैक्स इज बी, वी मैक्स इज एक्चुअली बी, हाउ कैन वी अचीव ग्राफ ए? सो ग्राफ ए कैन बी अचीव्ड व्हेन योर ए एंड सी bind with each other. I mean A and C work. When drug A and this is graph number A है ना, ये ग्राफ A B C D है. When drug A and C binds at the receptor, तब जाके allosteric activation होगा. ठीक है, allosteric inhibition, that means they will be acting at a different site. For example, this is allosteric inhibitor, this will be acting at a different site, right? And after acting at a different site, they can bring some configurational changes in the receptor. Because of the configurational changes that they are going to make in the receptor, this receptor will not be able to take the new compound or any other drug. No matter how much dose you give, it will not be accepting any new drug. So this is called allosteric inhibitor, or also known as non-competitive inhibitor. Is it making sense, Dr. Reformer? I hope it is making sense. This was the basic concept actually. This one is mainly talking about, this is not potency. Potency मैंने बताया left and right है ना, log dose पे आएगा. Potency will always come on the log dose. Okay. So this is mainly, yes, it's one of the PYQ. Drug X that we have, it is talking about the agonistic action, and this graph has been asked already. Remember, this is the agonist, whose in intrinsic activity score will be +1. This will be your partial agonist, this will be your antagonist, and this will be your inverse agonist. Okay, inverse agonist. So I hope all of you guys have got this, and you will not make mistake. With respect to intrinsic activity score, agonist has an intrinsic activity score of +1. This will have any score from 0 to 1. Antagonist will have intrinsic activity score of 0, and inverse agonist have intrinsic activity of -1. I hope it is making sense to all of you. Next one, similar to this, I have already taught you. You can easily mark this, you can easily do this question. This is pretty simple. In the given image, which of the following statement is true? Right, so 4 statements are there. Which statement do you think is going to be true? I hope it is visible to all of you guys. Drug D is more potent, more efficacious than A. B is least potent. Potency of C is same as D. Potency of A is more than C. So I hope all of you guys have got the concept and you are not going to make mistake here. So potency, ये potency efficacy वाला graph same रहेगा, concept will be same. So order of the potency will be B, A, C, D, because it goes from left to right. It goes from left to right. Then we will talk about the efficacy. We'll talk about the efficacy. Efficacy में if you pay attention here, efficacy में A, C and D, they are in the same line. That means Eiffel Tower, the height of the efficacy is same, right? So efficacy में A is equal to C is equal to D, and सबसे छोटा height is with the B. So B is the least efficacious. So can I say drug B here is most potent? Just asking true and false. Drug B is most potent and least efficacious. Is it true or false? Just tell me either true or false. All of you, if you have been understanding this already, then we are going to have a different kind of question इसके बाद वाले में, जो कि आप सब लोग enjoy करेंगे. You guys will enjoy the next question that is coming for all of you guys. I hope all of you guys will agree with me, and all of you guys are going to tell me yes, it's a true statement. It's a true statement. Very good. चलिए, इसमें similar to this, there is one more question. In the given image, which of the following statement is true? So the more you exercise, इसके बाद से दोबारा ये नहीं पढ़ना है. समझ में आ गया what is potency, what is efficacy, and sometime there will be questions like which will have option like this, X, Y, Z. Now tell me, Y is less potent than Z. X and Z are equipotent. X is more potent than Y and Z. Y is more efficacious than Z. ABCD में all of you please mark. If you have understood, then you will not make mistake. You will never make mistake in fact in this concept. All of you please try. Some of you are not trying at all. Some of you are still simply looking at others. है ना? Now the correct answer for this one is X is more potent than Y and Z. So X of course is more potent, because if you are going to look at the potency order, the potency order will be X followed by Y followed by Z, X, Y, Z, X followed by Y followed by Z. Okay, because potency, it is always looked at the log dose, and efficacy, if you see efficacy, now if you compare, let us see X and Z का line क्या intersect कर रहा है, almost intersect कर रहा है, I guess, है ना, almost intersect कर रहा है. So we can actually say that X and Z are equi-efficacious. X and Z are equi-efficacious followed by Y. ठीक है, तो I think basic concept remains the same. Now this is what I need to check your knowledge here. In the shown image, if you see, we have on the y-axis plasma concentration, and this is your time. Which of the following drug has rapid rate of absorption? Drug A, drug B, drug A is equal to drug B, and B is more than, that is B is faster than A. You have to be very very careful for marking the answer to this question. Go ahead please, all of you. एक ग्राफ दिया है, इसमें दो ड्रग दिया गया है. On the plasma concentration, if you see, this is one of the plasma concentration. Right, ये इसका maximum plasma concentration. In the given image, which of the following drug has rapid rate of absorption? Two drugs are given. एक ड्रग का absorption दिया, फिर दूसरे का दिया है. अब पूछ रहा किसका रैपिड रेट है. आई होप कि सारे लोग इसका जवाब सही मारेंगे, एंड दिस इज प्रीटी सिंपल कॉन्सेप्ट. वेरी गुड, एंड आई एम प्रीटी हैप्पी दैट मोस्ट ऑफ यू आर गोइंग करेक्ट. नाउ व्हाट इज दिस ग्राफ शोइंग? दिस ग्राफ इज शोइंग absorption, right? It is showing what? Absorption. So whenever you look at any graph, guys, very very simple. Now whenever you look at any graph, let's say you are going to see a graph, right? Now if there is a time on the x-axis and this is the plasma concentration on the y-axis, let us talk about a single drug. Whenever we give the drug orally, what will happen? The drug will increase slowly in the plasma, concentration will slowly increase, right? Slowly it will increase, and after some time it will achieve a plateau and it will come down. Is it making sense to all of you? Now there is a time, I think this information I have given you in the previous image as well, that there will be time when the plasma concentration will be at peak. So this is known as your peak plasma concentration, है ना? Plasma concentration at so this we can call it as a Cmax, maximum plasma concentration, and this maximum plasma concentration is achieved at certain time. So this particular time that we have, this we are going to call Tmax. It is actually one of the P by Q. ये एक बार ऑलरेडी 18-19 में ये आ चुका है. Tmax, that means कितने टाइम पे मैक्सिमम प्लाज्मा कंसंट्रेशन आया, राइट? And now if you are going to compare this with one more drug, and the other drug that you are going to compare with is having a little slow rate of absorption, like ऐसे गया, ऐसे आया, something like this. So if the examiner is asking rapid rate of absorption, so whenever they are going to talk about rate की बात जहाँ कहीं भी होगी, immediately क्या होगा? टाइम की बात आएगी, इमीडिएटली टाइम की बात आएगी. ठीक है. नाउ इसका टी मैक्स देखिए, ए का टी मैक्स ए ये है, टी मैक्स ऑफ ए, एंड दिस इज द टी मैक्स ऑफ बी. दिस इज द सी मैक्स, दैट इज कंसंट्रेशन मैक्सिमम ऑफ ए, एंड दिस पॉइंट हियर इज द कंसंट्रेशन मैक्सिमम ऑफ बी. आई होप इट इज मेकिंग सेंस टू ऑल ऑफ यू. सो व्हेनेवर दे आर गोइंग टू टॉक अबाउट द रेट ऑफ एब्जॉर्प्शन, सबसे पहले आई मीन प्लाज्मा कंसंट्रेशन किसका आई हो, टाइम की बात करेंगे अगर, राइट? कितने टाइम पे हुआ, कितने टाइम पे वो सी मैक्स पे पहुंच गया, दैट इज योर रेट ऑफ एब्जॉर्प्शन. सो व्हेनेवर इट कम्स टू रेट की बात अभी, तो वो कैसे मेजर करते हैं, राइट? किस रेट से है, कितने घंटे के हिसाब से, कितने मिनट के हिसाब से, तो वी ऑलवेज कैलकुलेट इट ऑन द बेस ऑफ टाइम. सो ऑलवेज रिमेंबर, ड्रग ए का टी मैक्स पहले आ रहा है, सो ड्रग ए इज है मोर रैपिड रेट ऑफ एब्जॉर्प्शन. ए और बी का सेम नहीं है. ठीक है, ए और बी का सेम नहीं है. नाउ विच ऑफ द फॉलोइंग ड्रग इज अचीविंग सी मैक्स अहेड ऑफ टाइम? अगेन ए. बी का सी मैक्स इज लेसर. दोनों का सी मैक्स सेम नहीं है, दोनों का टी मैक्स भी सेम नहीं है. आर यू गाइस फॉलोइंग मी हियर? है ना. रैपिड लेस नहीं होगा, फास्टर होगा. फास्टर इज द, ठीक है. नाउ एज आई एम कमिंग टू द सेम कॉन्सेप्ट, डॉक्टर रिचा पाल, आई एम कमिंग टू द सेम कॉन्सेप्ट. If we are going to see, let's talk about this drug where we have seen Cmax, that is the extent of the Cmax that we are having, it is the plasma concentration, which is the maximum plasma concentration. And if we are going to compare this one with this area, the time and the plasma concentration for the drug, this is acquired by a graph, so we call this one as a area under curve, right? Area under curve that we have, it will be telling you the extent of absorption. So कौन सा ड्रग कितने देर के लिए एब्जॉर्ब हो रही है, कितना फास्ट हो रहा है या स्लो हो रहा है, एंड इट इज गोइंग टू स्टे इन द सर्कुलेशन और इन द बॉडी फॉर हाउ मेनी मिनट और फॉर हाउ मेनी आवर. ठीक है. सो ओवरऑल एक्सटेंट ऑफ एब्जॉर्प्शन विल बी गिवन बाई area under curve. Area under curve will be giving you extent of absorption. Therefore, if I ask you one more very simple question, can you tell me T max will be giving you what? T max क्या दे रहा था? It is going to tell you the rate of absorption. Please pay attention. This question, both of them has been asked. Both of them are PYQ actually. ठीक है. एक rate of absorption, the rate मतलब time. So A का आपने ज़्यादा बता दिया, इसी के वजह से बताया because T max of A is achieved ahead of time. ठीक है. AUC extent of absorption, T max rate of absorption. C max क्या देता है? What is the response of C max? C max क्या देता है? The plasma concentration, maximum plasma concentration. C max क्या देगा? C max will be maximum plasma concentration that is achieved. ठीक है. Okay. Now similar to that, which of the following the best measure of extent of absorption? So I think all of you guys have seen already. The answer to this question will be area under curve, and this is the area that is being covered by graph number A. So its extent of absorption will be different as compared to graph number B. Best measure of extent of absorption, that is your area under curve. Rest of the thing I have told you already. Rate of absorption also all of you guys are aware, that is area under curve. Let us see the next one. Very simple question. So I hope graph related question, potency, efficacy, competitive inhibitor, non-competitive inhibitor, area under curve, everything, if it is asked, you guys can easily mark. I hope yes. Which of the following schedule deals with the sale of the shown drug? So there is a drug name that is given here. If you see, very easy drug. एक ड्रग का नाम बस दे दिया गया और पूछा गया कि which of the following schedule deals with the sale of the following drug? Can you tell me? Schedule E, Schedule G, Schedule Y, Schedule W. So again, this is just an image based question. So we are trying to give you some information. So it's not only images that are important, it's actually whatever we are discussing around these images are also important. Okay. Now this drug is paracetamol. So paracetamol, is it generic name or brand name? This is generic name, right? So examiner is simply asking that the sale of generic drug is coming under which one? Generic drug. So all the generic drug, sale and manufacture of generic drug, सेल एंड मैन्युफैक्चर ऑफ जेनेरिक ड्रग, तो वर्ल्ड वाइड ये सेम नाम से अवेलेबल होते हैं. दैट विल बी शेड्यूल W, सेल एंड मैन्युफैक्चर ऑफ द जेनेरिक ड्रग्स, राइट. दिस विल बी कमिंग अंडर शेड्यूल W. ओके. शेड्यूल E क्या होता है? व्हाट इज शेड्यूल E? सो यू शुड नो अबाउट दिस एज वेल. इट इज एक्चुअली द लिस्ट ऑफ पॉइजनस सब्सटेंसेस अंडर सिद्धा यूनानी आयुर्वेदा, अंडर सिद्धा Unani and Ayurveda. So have you ever tried Siddha, Unani or Ayurvedic drugs? They are not very palatable. थोड़े bitter होते हैं. And whenever you eat anything bitter, the expression from your mouth will be E क्या खिला दिया. The one that brings E from your mouth, that will be, है ना, Schedule E. G वाला, it will gives you guideline not to be taken except under medical prescription, है ना. ये intake की बात करता है and it is always coming with a caution. It always comes with a caution not to be taken except under medical prescription or supervision. तो ये hormonal anti-cancer drugs are very good example of schedule G. Y is mainly dealing with the clinical trial. right? Why is mainly dealing with the clinical trial. Now, do you know that for the expiry period of a drug, which schedule is going to deal with the P for period, expiry period? Then all the drug that require prescription of this particular schedule says that this drug require prescription of an RMP, prescription of a RMP. What is RMP? Who is RMP? Registered medical practitioner. This will be your schedule H. And last but not the least, that you should never forget, will be list of psychotropic drug. List of psychotropic drug that require a specific license for manufacture and sale, and they usually also have high abuse potential. They have high abuse potential. This is going to be our schedule X. तो एक्सेस हमेशा साइको होते हैं या होती है, जस्ट याद करने के लिए है. लिस्ट ऑफ साइकोट्रोपिक जो हम देंगे, हम सब क्या हैं? हम सब आरएमपी है. तो याद कर लीजिए कैसे, दैट वी ऑलवेज नीड अ प्रिस्क्रिप्शन फॉर आरएमपी. तो आरएमपी कौन है? हम सब है आरएमपी. दिस पर्टिकुलर सेल ऑफ दिस ड्रग रिक्वायर प्रिस्क्रिप्शन ऑफ आरएमपी. तो व्हाट इज द नेम ऑफ शेड्यूल? एच. एच फॉर हम है आरएमपी. एच फॉर हम है आरएमपी. ठीक है. नाउ टेराटोजेनिक ड्रग दैट वी हैव, इट इज नॉट गिवन विद द शेड्यूल्स. कैटेगरीज वो कैटेगरी वाइज होते हैं. कैटेगरी इट विल बी A, B, C, D and X. So this will be where this will be your schedules, right? So this will be your category. Category may remember there is a T here, T for category. So this will be assessing the risk of teratogenicity. Dr. Divya Kumari. I hope that you have attended my previous class. If you have not, then definitely this much information should be good enough for you. सबको याद आती है एक्स साइको थी. हाँ, एक्स साइको थी था. ठीक है. चलिए, लिस्ट ऑफ साइकोट्रोपिक ड्रग एक्स हो गया. डब्ल्यू फॉर वर्ल्ड वाइड वैसे ही अवेलेबल है, जेनरिक ड्रग. वाई शुड आई टेक योर ड्रग? तो बोलेगा लेट्स डू अ क्लिनिकल ट्रायल वेन एवर इट कम्स. वाई शुड आई टेक? लेट्स डू क्लिनिकल ट्रायल. द वन दैट गिव्स यू गाइडलाइन दैट विल बी शेड्यूल जी. ई फॉर ई, जो आपके मुंह से ई निकाल दे, दैट इज ई. ऑल द शेड्यूल क्विकली वी हैव रिवाइज्ड. वी कैन टेक द नेक्स्ट क्वेश्चन. Over the shown drug strip, the red line depicts that the drug belongs to. तो कहीं पे भी ये red line का मतलब क्या हुआ, right? These red line, it is mainly for antibiotics only. Red line on the left hand side, it is mainly for the antibiotics only. Only antibiotics will have this red line, no other class of drug. ठीक है. चलिए बताइए. What do you think is the correct answer for this one? Over the shown drug strip, the red line depicts what? Yes, Dr. A. Om, how can I help you? बताइए क्या परेशानी हो गई? कुछ बात समझ में नहीं आई तो बताइए. I hope all of you guys are okay here. That H1, right? So this red line means it is coming under H1. Schedule H1 that we have, it came into existence in year 2013. It came into existence in year 2013. It is for antibiotics only. Mainly it came into existence to check over the unauthorized sale of antibiotic. Unauthorized sale of antibiotics. Now in our country, quackery is practiced to the maximum. है ना? ठीक है? Okay. आपकी प्रॉब्लम बहुत ही हसीन है डॉक्टर ओम. इतने हसीन प्रॉब्लम का जवाब मैं यहाँ पे नहीं देना चाहता. ठीक है, अभी के लिए फार्मा पढ़ते हैं. चलिए, H1 आई थिंक इट्स मेंशन्ड हियर दैट इट इज it came into existence 2013. ठीक है, and all the drug that are coming under this one will have a red line on the left hand side. Okay, and a very good example here will be this one. Can you see here? There is something called Pulmocef. Pulmocef 500. It is known as your brand name. What is Pulmocef 500? It is known as your brand name. Brand name. Okay. Cefuroxime Exitil क्या है? This Cefuroxime Exitil that we have, this is the generic name. Cefuroxime Exitil is the generic name. So sometime they can ask you this as well, right? What does the IP means? IP means this drug, information of this drug has been taken from Indian Pharmacopoeia, from the Indian guideline, right? Indian guideline. See, I was taking it very lightly, Dr. Om. मैं बहुत ही डॉक्टर पी, आई टेक केयर ऑफ द हैंड राइटिंग, सॉरी अबाउट दैट, आई टेक केयर ऑफ द इंक साइज, वो मैं देख लूँगा अगले वाले क्वेश्चन से, sorry about that. And Dr. Om, I am taking it lightly. I was not thinking that it's really a problem. I thought you were just trying to थोड़ा सा deviate कर रहे हैं क्लास को. But if that is the case, then definitely you should take legal help. That is what I can advise. I'll use the bigger ink size. Thank you very much. Okay, now the shown teratogenic effect is seen with. Now there is teratogenic drugs. It is coming under what? All the teratogenic ones are given by the category. Who has given the category? Category has been given by US FDA. ठीक है? And how many categories that we know? The categories that we are having are category A, B, C, D and X. Again remember, X category वाले drug को भी नहीं देना है. It is highly teratogenic. No matter what is the type of benefit they offer, you don't take it. तो कितना भी बोलती है कि मैं आपको ये बेनिफिट दूंगी या ये बेनिफिट दूंगा, राइट, नहीं लेना है. नो पॉसिबल बेनिफिट कैन आउटवे द रिस्क. ओके, कैटेगरी एक्स ड्रग दैट वी हैव, नो पॉसिबल बेनिफिट कैन आउटवे द रिस्क. नो पॉसिबल बेनिफिट कैन आउटवे द रिस्क. कैटेगरी एक्स का ड्रग को कभी नहीं देना है. Can you give me some example? Okay, this condition here is known as your aplasia cutis. This condition is aplasia cutis, also known as scalp defect, associated with your methimazole. Other drug that can be associated with this one will be your carbimazole. Methimazole, other drug जो इसके साथ associated होगा, that will be carbimazole. Now, can I quickly take this opportunity to quickly discuss the important one, right? अरे भैया, मुझे क्या पता कि प्रीति मैम क्या यूज़ करती है. मुझे पहले कोचिंग लेने दो जाके उनसे. आई थिंक ये विजिबल है कि नहीं है, ये देखो ना. मेक इट मोर थिक. आपके थिक के चक्कर में सिस्टम हैंग हो गया. अब मैं फ़ोन करता हूँ अभी आपकी प्रीति मैम को कि भैया हमें बताओ. चलो. So as I was telling you about teratogenic drugs are always a very good part of the examination, and examiner always asks questions on teratogenic one. So what I will do, I'll quickly take this opportunity to discuss one very important topic from the teratogenic drugs as well. अरे यार.
Voice over on. Landscape. Alert. Don't allow. Button. Home beat. Voice over off.
Sorry about this short interruption. Let me just open. ठीक है, अभी सही हो गया आई गेस. I think things are fine now. Sorry about this. Things are fine now. Chalo. So let us quickly understand and quickly try to make a list of important teratogenic drugs that we have. For example, all of you guys are already aware about valproate. It causes what? Spina bifida. Valproate causes spina bifida. Same kind of side effect can also be seen with your carbamazepine. It can also lead to some neural tube defect. Then we also can check out the phenytoin, a very important drug that will be leading to fetal hydantoin syndrome. Fetal hydantoin syndrome. Do you guys know that warfarin as an anticoagulant can lead to fetal warfarin syndrome, also known as your Contradi syndrome? Fetal warfarin syndrome, also known as your Contradi syndrome. Then what are the other teratogenic drug? Thalidomide, I mean world famous, no? Thalidomide disaster, सबको पता होगा. This will be leading to a side effect known as your phocomelia, right? Phocomelia is a side effect. Then don't you know that drugs like your methotrexate, they can also produce teratogenicity like neural tube defect and all, can also be caused by this class of drug, right? They can also cause this teratogenic effect. Then we are also having drugs like your erythromycin. Erythromycin, not erythromycin as a whole, but erythromycin का एक salt जो है erythromycin estrolate, it can cause cholestasis and they can also lead to a problem known as your CHOPS, congenital hypertrophic obstructive pyloric stenosis, है ना? Pyloric stenosis, olive shaped lump, non-venous vomiting, है ना? तो ये बहुत important है. Then we are also having cotrimoxazole. Cotrimoxazole as a drug can lead to kernicterus. This kernicterus can also be seen as a teratogenic effect post post birth also, newborn में अगर देते हैं cotrimoxazole, it can also lead to this one. It is also given the name as a yellow baby syndrome. Now wherever it comes the term yellow baby, I'm pretty sure all of you guys must be thinking already कि सर ग्रेप है ना, एक और जो हमारा ड्रग है जिसका नाम है क्लोरमफेनिकॉल, it can lead to your bone marrow suppression, that can lead to your gray baby syndrome. Yes or no? Then we are also having any of the aminoglycoside like streptomycin, capreomycin, kanamycin. They can lead to your ototoxicity, nephrotoxicity, and they can also lead to your nephrotoxicity. Lithium, world famous, सबको पता है ना कि lithium is going to be associated with the Epstein anomaly, right? It will be Epstein anomaly, all right? That is Blue Man syndrome. It's not a teratogenic effect, Dr. Rameshwar Nayak. It's not a teratogenic effect. Okay. Now important teratogenic effect I have summarized here before all of you guys, है ना? तो 10-12 जो important teratogenic effect है ये हमेशा हर एग्जाम में आते हैं. एक दो बार छोड़िए, हर एग्जाम में ऑलमोस्ट आपको मिल जाएगा. 10-12 मैंने जो लिस्ट लिखवा दिया इससे आपको मिल जाएंगे क्वेश्चंस. नाउ लेट अस गो टू द नेक्स्ट वन. A 30-year-old patient of epilepsy presented with the following condition. There is a history of hypertension. He was on long-term therapy for his epilepsy and hypertension. Which of the following agent can cause the shown condition? I am not able to move this image, but whatever is written behind this image, I have already read it. So, which of the following, this patient is having history of hypertension and epilepsy. So, which drug can cause the shown condition? Phenytoin, lamotrigine, nifedipine, A and C both. I am pretty sure all of you guys are marking A and C both, and that is a correct answer actually, because antihypertensive drugs like amlodipine, nifedipine has been shown to have a side effect known as your gum hypertrophy. Now can I quickly ask, can you tell me some immunomodulator that is having this gum hypertrophy as a side effect? Which immunomodulator that is also having gum hypertrophy as a side effect? So we know there is a drug known as your cyclosporine. This is also associated with your gum hypertrophy as a side effect, है ना? It's a calcineurin inhibitor. Cyclosporine is a calcineurin inhibitor. I hope the handwritings are okay here and you guys are able to read it now. Now a drug was tested in electrophysiology lab. This question has already been asked guys in the recent examination as well. A drug is tested in the electrophysiology laboratory to determine its effect on the cardiac action potential in the normal ventricular cell. The results are shown in the diagram. Okay, and the shown diagram resembles this drug. Okay, so let us see which drug that we are talking about. If you look at this image here, guys, we have first and foremost we are having the control. So blue one is the control one. और ड्रग कौन सा है? ये ड्रग ब्लैक वाला जो है वो ड्रग है. ठीक है, कंट्रोल मतलब नॉर्मल कौन सा है, वो ब्लू वाला है, तो दिस ब्लू वाला ऊपर वाला जो है दिस इज द नॉर्मल कंट्रोल. नाउ टेल मी विच ड्रग कुड हैव कॉज दिस काइंड ऑफ अफेक्ट. सो जब तक आप बताएंगे मैं जब तक थोड़े बहुत आपके लिए ये ड्रॉ कर ले रहा हूँ, जस्ट टू मेक श्योर दैट यू गाइस आर ऑन द सेम पेज. जल्दी से बताइए, प्लीज लेट मी नो योर आंसर्स, प्लीज फास्ट, ऑल ऑफ यू प्लीज लेट मी नो योर आंसर्स. And last time I actually taught this, and immediately after the revision session there was exam, I think NEET PG exam था जो 2022 वाला हुआ था, and a question came, है ना. So what do you see here, there is some decrease in the slope of depolarization, isn't that? There is some decrease in the slope of depolarization. If you see, the slope of depolarization is coming, right, it is lower down, but ultimately or overall there is no change in the action potential duration. There is no change in the action potential duration, it is same. दोनों ही सिनेरियो में सेम है. Always remember guys that whenever we talk about class 1 anti-arrhythmic drug, whenever we talk about class 1 anti-arrhythmic drug, let me just mention about that. Let us say, ये मैंने गलती से ड्रॉ कर दी, इसका कोई मतलब नहीं है ज़्यादा. Let us just quickly try to draw this one. All the class 1 antiarrhythmic drug will have something like this, a normal action potential duration. Let us say this is one of the normal action potential duration, and when I am going to give class 1 antiarrhythmic drug, let's say class 1A antiarrhythmic drug, 1A will be sodium blocker along with the potassium blocker. Because of sodium blocker and potassium blocker, what will be the outcome? Let us see. Because of sodium blocker, there will be decrease in the slope of depolarization. Overall slope of depolarization will be decreased. Because of potassium blockade, the repolarization will be slowed down, and because of that, overall action potential duration will increase. So don't you think that whenever we use any class 1A antiarrhythmic drug, there will be increase in the action potential duration, and this action potential duration in the ECG will be corresponding with your QT interval? बात समझिएगा, स्लोप ऑफ डिपोलराइजेशन भी स्लो हो रहा है, एंड ओवरऑल एक्शन पोटेंशियल ड्यूरेशन इज आल्सो इंक्रीज. स्लोप ऑफ डिपोलराइजेशन एवरीथिंग इज स्लो डाउन. नाउ व्हाई एम आई ड्राइंग दिस? बिकॉज एग्जामिनर कैन आस्क यू दैट विच ऑफ द फॉलोइंग ड्रग इज शोन हियर. सो क्लास 1A एंटीएरिथमिक ड्रग लाइक quinidine, procainamide, disopyramide, these are class 1A antiarrhythmic drug. And let us talk about class 1B antiarrhythmic drug. Let us say this blue one is the normal action potential duration, and next one that I am going to talk here is a class 1B antiarrhythmic drug, which is a sodium channel blocker, but it's a potassium channel ka opener. So what will be the outcome? Let us understand. So because of sodium channel blockade, boys and girls, the slope of depolarization will definitely decrease. I hope you guys can easily understand that there is a decrease in the slope of depolarization. But because the potassium channel is opened, the potassium efflux will be more rapid, and this leads to decrease in the overall slope of repolarization. So always remember, class 1B में potassium बाहर जाएगा, 1B में potassium will go out, and the action potential duration will be decrease in the action potential duration as compared to here, where there is increase in the action potential duration. Drugs like lidocaine, phenytoin, tocainide. So again, this is not a class of antiarrhythmic drug, but if you have attended my antiarrhythmic class, you know that 1B जो बाहर खड़े रहते हैं, they are always very proudy, and they say I am so important that they all like to phone me. I am so important that they all like to phone me, like lidocaine, tocainide, phenytoin, and maxilitine. Right, so I'm just writing it here, right, like to phone me, na? So of course they are very important class of drug. In most of the ventricular arrhythmia we use them. Then let me just give you one more example. That let us talk about one more scenario. Let's say this is one third one, and this one is class 1C antiarrhythmic drug, which is mainly and only sodium channel blocker. So what will be the outcome, boys and girls? See, सिर्फ इसमें मेरा उद्देश्य आपको ग्राफ पढ़ाना है, कैसे आप आइडेंटिफाई करोगे, ठीक है. Now there will be definitely slope of depolarization will decrease because sodium channel is blocked. Now if there is no effect on the potassium channel, do you think there will be any change on the slope of depolarization? The answer is no. So action potential duration will be unchanged. So there will be no change in the action potential duration. Action potential duration remains normal, neither increase nor decrease. Now what is happening here, action potential duration is normal here. That means we are definitely talking about a class 1C antiarrhythmic drug. और 1C antiarrhythmic drug ये सारे C ग्रेड वाला काम करते हैं. C ग्रेड का मतलब जिस किंगडम में क्वीन प्रिंस और दासी रहते थे, क्लास 1 एंटीरिथमिक ड्रग इन द सेम किंगडम. दिस इज अ स्टोरी. व्हेन यू अटेंड माय एंटीरिथमिक क्लास, आई हैव टोल्ड यू अ स्टोरी. देयर इज अ किंगडम वेयर देयर इज अ क्लास 1A, क्लास 1B, क्लास 1C. ए क्वीन प्रिंस दासी, बी दे आर बाहर खड़े हुए लोग, वेरी इंपॉर्टेंट, लाइक टू फोन मी. एंड 1C ये सारे C ग्रेड वाले काम करते हैं. व्हाट आर द C ग्रेड वर्क? C ग्रेड वर्क विल बी फ्लोर पर मॉपिंग एक्सेट्रा वाले वर्क. फ्लोर पर मॉपिंग एक्सेट्रा विल बी योर फ्लिकेनाइड, propafenone. Their structure is like propranolol, so they have beta blocker property, है ना. Moricizine and NK-nide. Okay, so this is class 1C antiarrhythmic drug. So you can check it out. If there is no change in the action potential duration, possibly it's a class 1C antiarrhythmic drug. The option from class 1C is only flecainide. Why not amiodarone, guys? Why not amiodarone? Because amiodarone is class 3 antiarrhythmic drug that happens to be only and only potassium channel blocker. Please pay attention here. This is the most important graph that I am going to draw, and possibly it is the most potential MCQ for the upcoming examination, right? So this will be one of the normal action potential duration, and whenever you see a graph like this, and in this graph, if you see that slope of depolarization is not changed, slope of depolarization is almost same, or it is unchanged. I'm just trying to show you with the red line that slope of depolarization is not changed at all. It is almost same, but the only change that is shown here is in the slope of repolarization. So whenever you say only change in the repolarization, that means increase in the action potential duration only, increase in the action potential duration only, there is no change in the slope of depolarization. This is possibly a class of class 3 antiarrhythmic drug. That means it is only and only potassium channel blocker. So this will be class 3 antiarrhythmic drug. I hope all of you guys have got this, and you will never make mistake in this type of graph if it is going to be asked at any point of time in your examination, है ना. Class 1A drug will be your quinidine, procainamide, disopyramide. ठीक है, procainamide, disopyramide. Okay, great. चलिए, next question. The shown side effect is seen due to which of the following drug? Acetazolamide, bematoprost, pilocarpine, brimonidine. I hope all of you guys are okay here, comfortable with the concept of whole action potential duration. वो मैंने जल्दी से आपको बताया, and we spent good amount of time in that concept. Okay, so this is a case of hypertrichosis. This is a case of what? Hypertrichosis, या इसको trichomegaly बोलते हैं. That can be associated with your drugs PGF2 alpha analog, right? So your PGF2 alpha analog, right? PGF2 alpha analog, latanoprost, bematoprost, tafluprost, right? Do you know what are the important side effects of PGF2 alpha analog? They cause pigmentation of iris. They can lead to problems like pigmentation of iris. They can lead to problem like growth of eyelashes. और यही तो हो रहा है, growth of eyelashes, है ना, hypertrichosis. Then they can also lead to problem like your foreign body sensation. Foreign body sensation. They also cause your fat atrophy of the orbit. Because of the fat atrophy of the orbit, there will be enophthalmos, and there can also be acute anterior uveitis. They can also lead to your cystoid macular edema, but again these are not a very common kind of side effect. ठीक है, so you can remember PGF2 alpha analog का side effect PGF2A for alpha. PGF2 alpha का side effect will be PGF2 alpha. Very easy to remember, PGF2, right? Pigmentation of the iris, growth of eyelashes, जिसको बोलते हैं hypertrichosis, trichomegaly, foreign body sensation, and fat atrophy of the orbit leading to enophthalmos and acute anterior uveitis. A patient was an anti-cancer drug for his testicular carcinoma present with the shown condition. Which of the following agent can cause this? So if you see here in the image, there are bluish gray या grayish blue, bluish gray skin discoloration. So मैं इसको बोलता हूँ this drug, इस drug के नाम में blue word आता है. There is something called your bleomycin. Bleomycin. This is a case of flagellate dermatitis. Flagellate dermatitis, right? This is a case of flagellate dermatitis that can be caused by your bleomycin. Bleomycin is anti-cancer antibiotics. Okay, the shown image is representative of sympathetic neuron nerve ending. It's a sympathetic neuron nerve ending. Which of the following drug block the carrier represented by Z? Right? Which one will be, which of the following blocks the carrier represented by Z in the image? So if you see in this image, we are having Z here, somewhere here at the point of arrow, Z is there. Can you guys see this one? I hope this image is pretty visible to all of you guys. So in the sympathetic neuron, which of the following drug will be mainly represented, or drug will be acting at the carrier number Z? कौन सा ड्रग होगा जो Z पे काम करेगा? बॉटुलिनम टॉक्सिन, एम्फेटामिन, रिजरपिन, कोकेन. ऑल ऑफ यू प्लीज ट्राई मार्किंग गाइज, प्लीज सब लोग ट्राई करिएगा, सब लोग ट्राई करिएगा. अमलन रॉय, इट इज टेलिंग बॉटुलिनम टॉक्सिन. वेरी गुड है ना, वेरी नाइस. All of you are marking very good. Now my simple question to all of you guys, that whenever we look at the parasympathetic nerve terminal, जब भी हम parasympathetic nerve terminal देखते हैं, in the parasympathetic nerve terminal we do have acetylcholine here, and the release of the acetylcholine will be inhibited by the botulinum toxin. Now botulinum toxin, is it associated with the sympathetic neuron or parasympathetic neuron? Simple question. All of you are marking A. Are you guys not reading? I have already underlined the problem. Sympathetic neuron की बात करें, पैरासिम्पथेटिक की, और एग्जामिनर यहीं पे आपको राइट लपेटेगा. तो आपको ये देखना है कि एग्जामिनर का मंशा क्या है, एग्जामिनर क्या जानना चाहता है आपसे, बेसिक कॉन्सेप्ट पूछ रहा है, सिली मिस्टेक करवाना चाह रहा है, क्या चाह रहा है ना. नाउ इफ यू सी, वी हैव हियर नॉरएड्रेनालिन यहाँ पे है. Whenever excessive of noradrenaline is there at the synaptic cleft, the majority of them will be reuptaken through a transporter, and the name of a transporter is a norepinephrine transporter. The drug that can inhibit this reuptake by the transporter, ये drug जो inhibit करता है, उस drug का नाम क्या? What is the name of a drug? The drug that can inhibit this one will be your net inhibitor. कौन कौन से होते हैं? The drug that can inhibit will be your cocaine, TCA, SNRI, serotonin noradrenaline reuptake inhibitor, cocaine, tricyclic antidepressant. These are all going to be your net inhibitor. So very simple question, that if the examiner is going to ask you that Z क्या कर रहा है? What is the function of Z here? What is the function of Z here? Z is simply causing reuptake of your neurotransmitter. If it is a sympathetic neuron, then you can easily understand that the sympathetic neuron will be coming, it will be stored at number 4, it will be noradrenaline, it will be released. Noradrenaline is released at the synaptic cleft and it will be working, and the reuptaken will be done by Z transporter, मतलब norepinephrine transporter, that can be inhibited by your cocaine. Now if I ask you that at point number Y कौन सा ड्रग काम करेगा? Y अगर ये noradrenergic neuron होगा, so which can inhibit the uptake of the neurotransmitter in the synaptic vesicle. In the vesicle, in the sympathetic neuron, जो रिजर्वॉयर नहीं बनने देगा, that will be your रिजरपिन. इसका काउंटर पार्ट जो पैरासिम्पैथेटिक में होता है, that is your वेसामिकॉल. पैरासिम्पैथेटिक में क्या होता है? वेसामिकॉल. Here it will be रिजरपिन, है ना. रिजरपिन is one of the VMAT2 inhibitor. Then we can also have deutrabenazine, tetrabenazine, valbenazine. Again, this is not the important point here, that you have to know the image, but what I am discussing here is the basic concept that you should also check it out, है ना. Rizarpine, deutrabenazine, valbenazine, tetrabenazine, all of them are VMAT2 inhibitor. Are you guys following me here or not? Then again one more question, which of the following drug can inhibit the transporter number X? If it is a sympathetic neuron, which can inhibit the transporter number X? The name of a drug, because here we have the tyrosine that is going inside, and the name of the drug that can inhibit this one will be your metyrosine. Is it making sense to all of you? Are you guys following me here? Are you guys following me here? Yes. Metyrosine, yes. Okay, great. So आगे चलते हैं. In the shown image, the effector cell here is the pupillary constrictor muscle. So this is थोड़ा सा twisted question. If you know already that on the pupillary constrictor muscle, which type of receptor is there, you can easily mark this. Which of the following receptor is denoted by structure number 6? So here is the effector cell. And effector cell कौन सा है? The effector cell is pupillary constrictor muscle. तो नंबर 6 पे कौन सा रिसेप्टर होगा? तो सिंपली ये पूछ रहा है भाई साहब ये बता दो कि आई के पिपिलरी कंस्ट्रिक्टर मसल पे और सर्कुलर आइराइडिस पे कौन सा रिसेप्टर अवेलेबल है. सिंपल क्वेश्चन ऑफ एएनएस. इट इज आस्किंग एट द सर्कुलर आइराइडिस मसल और स्फिंक्टर पिपिले मसल विच रिसेप्टर इज प्रेजेंट. So it's very simple, no, that the receptor that is present here will be your M3 receptor, है ना, that is going to cause the active meiosis. The question like this that I have already explained to all of you guys, this is actually a case of phocomelia. Now examiner is asking what is the type of ADR. What type of ADR is this? Always remember, any teratogenic drug that we have, any teratogenic drug will always and always be type D kind of ADR. All of you guys are marking correctly, D for delayed kind of ADR. जितने भी teratogenic effect हैं, they all are coming under type D kind of ADR. 5-year-old child was prescribed with this drug for his epileptic episode whenever he had fever. The route of administration here is oral, intravenous, per rectal, sublingual. So I think ये देख के आप बता सकते हैं. 5 साल का बच्चा है. So again this could be a drug that is known as diazepam. कुछ लिखा नहीं है इस पे, but again अगर एपिलेप्सी में दे रहे हैं तो दिस कुड बी अ केस ऑफ व्हाट, फेब्राइल सीजर, एंड फॉर द फेब्राइल सीजर विल बी गिविंग पर रेक्टल. सो पर रेक्टल विल बी अ टाइप ऑफ अगेन एंटेरल रूट, है ना, एंटेरल में ही आता है एंटेरल, है ना. Okay, 55-year-old patient has acute chest pain and was given the shown drug for the immediate relief. All of the following are advantages of the shown. All of the following are advantages. The important points I have underlined. If you are little smart, you can easily pick it up. All of the following are advantages of the drug except rapid onset of action, can cause teeth discoloration, bypass, fast metabolism, commonly available. Go ahead, please. This drug is this one, nitrostat, nitroglycerin, 0.4 milligram per tablet. So all of the following are advantages except which of the following is not an advantage? Okay, great. So most of you guys are marking the correct answer. Guys, teeth discoloration is not an advantage, it's a side effect. It's not an advantage of this drug, है ना. Causing teeth discoloration, है ना, वो तो side effect हो गया ना. It's not an advantage. We are not using it because of this advantage, है ना, ये कोई advantage नहीं है. A patient with Parkinsonism was given the shown agent. So Nupro के नाम से है और इस drug का नाम है rotigotine, that is mentioned here. Correct about the route of administration of this drug: oral, intradermal, systemic, topical. Most of you are marking intradermal. Now always remember, intradermal that you are marking, it is a injectable route. यहाँ पे इंजेक्शन का कहीं नाम ही नहीं है. ये इतना प्यारा सा स्किन दिख रहा है, इतने प्यारे से स्किन पे एक पैच लगाया गया है. इंट्राडर्मल तो ये हो ही नहीं सकता. इंट्राडर्मल इंजेक्टेबल लाइक BCG वैक्सीनेशन इज इंट्राडर्मल. Montu test that we are going to use, it is a intradermal, or penicillin sensitivity testing that we are doing, it is also intradermal. तो ये intradermal तो है नहीं, ruled out हो गया. Next, topical, very good. Now topical, the definition of topical will be, site of action is same as site of administration. Site of action is same as site of administration. Now अब मुझे सोच के बताइएगा, this is a case of Parkinson disease where you are going to use a drug that is by the transdermal patch. लिखा भी हुआ transdermal patch. Rotigotine, if you are going to use in Parkinsonism in a rotigotine, let's say you are going to use a transcranial or somewhere that is close to your cranium, how it can help you in Parkinson disease. I mean, अगर यहाँ पे मैं बात करूँ टॉपिकल की बात करूँ, टॉपिकल का मतलब क्या हुआ, जहाँ लगाया वहीं पे काम किया. दैट मीन्स यहाँ लगाया तो यहीं पे काम किया, नेक पे लगाया तो नेक पे ही काम करना चाहिए. इट शुड नॉट शो द इफेक्ट समवेयर एल्स, है ना. तो टॉपिकल का डिफिनेशन क्या हुआ, साइट ऑफ एक्शन शुड बी सेम एज साइट ऑफ एडमिनिस्ट्रेशन. एग्जाम्पल ऑफ दिस वन कैन बी एनी काइंड ऑफ क्रीम, एनी काइंड ऑफ लोशन, इफ देयर इज आई ड्रॉप, if there is a nasal drop, right, eye drop, nasal drop for nasal decongestion, है ना. If there is a vaginal pessary, if you are going to utilize a vaginal tablet for vaginitis, vaginal pessary, जहाँ प्रॉब्लम है वहीं पे लगाया, that is topical. Again topical is ruled out. Next, it cannot be topical. तो दो तो मैंने रूल आउट कर दिया. Now the shown here, the shown route is known as your transdermal patch. Transdermal patch, it is coming under a systemic route of drug administration. It is coming under a systemic route of drug administration. So we will apply on the transcranium, and from there will be slow capillary absorption, and there will be changes, or there will be effect that is coming in the brain here. Okay, the transdermal patch is an example of systemic route या miscellaneous route में आते हैं ये. It is not in the oral और intradermal तो बिल्कुल नहीं है, और topical तो बिल्कुल नहीं. इसलिए जो B and D है, most of the students are stuck here, and after this you should not be stuck here. It's not a topical. Topical का definition क्या हुआ? Site of action should be same as site of administration. ये हो ही नहीं रहा यहाँ पे. Now transdermal patch, we are having many drugs that are coming under transdermal patch, right? Like for example, rotigotine is a transdermal patch. Can you tell me some other example of transdermal patch? Hyoscine is a transdermal patch for motion sickness. ठीक है. Do you know any other transdermal patch? Nitrates का transdermal patch आता है. ठीक है. Nitrates का transdermal patch. Diphenhydramine का transdermal patch आता है for motion sickness. Okay, so we have many transdermal patches, and they are not a topical route. The shown image is what? Very simple image. Is it ampule, vial, IV, infusion, or spensule? Now to ease down the burden for all of you guys, I'll tell you. The spensule that we have, if you look at the spensule, it will be like a capsule, and in the spensule you can easily see the small ये जो particles होंगे ना, ये आपको easily visible होंगे ऐसे. ये कैप्सूल में जो ड्रग होता है वो पाउडर्ड फॉर्म में होता है, बट स्पेंस्यूल में मॉलिक्यूल ऐसे आपको दिखेंगे आराम से, राइट. दिस इज ए स्पेंस्यूल. सो अगेन ये स्पेंस्यूल तो होगा नहीं. स्पेंस्यूल इज लाइक अ कैप्सूल. स्पेंस्यूल इज लाइक अ कैप्सूल. ठीक है. दिस इज एक्चुअली एम्प्यूल, है ना. एम्प्यूल में ध्यान रखिएगा, इसको कैसे याद करना है. ए फॉर एम्प्यूल, देखिए ऐसे ए के फॉर्म में आ रहा है. इट इज कमिंग इन द फॉर्म ऑफ ए. इट्स अ एम्प्यूल, राइट. And it is always and always for single use, है ना. Glass cover, there is no rubber covering here, है ना. Glass cover, single use, always and always. Okay, so this is a vial here, this is a rubber, है ना. ये rubber covering होती है. There can be multiple dosage from the vial. Okay, next, false about this mode of drug delivery. What is the false about this mode of drug delivery? So what do you see here? There is a machine here. Can you tell me what kind of machinery is this? What is going on here? If you want, I can give you a hint. This is a diabetic patient. False about this mode of drug delivery system is dose frequency is less, high risk of hypoglycemia, compliance can be high, it can be expensive. What is false? What is going on here? What does this image show? क्या क्या दिख रहा है आपको इस इमेज में, ये बताइए. इस इमेज में इसको क्या दिख रहा है? सेंट और सिनर. आपके नाम भी तो इतने मतलब मस्ती वाले हैं. सेंट या पापी, बताइए. What is going on here? That's what I wanted to see here. Okay. Monitor. बस यहाँ पे मॉनिटर आपको दिख रहा है और कुछ नहीं दिख रहा है यहाँ पे. इंसुलिन पंप, है ना. बिल्कुल, दिस इज अ इंसुलिन पंप दैट इज बीइंग शोन हियर. वेरी गुड, वेरी गुड. नाउ जब भी इंसुलिन पंप की बात आती है, रिमेंबर one of the very good advantages is that you don't have to take the drug again and again. So dosing frequency definitely is lesser, right? Dosing frequency definitely is lesser. Okay, very good. High risk of hypoglycemia नहीं. तो स्लो इंसुलिन इन्फ्यूजन होगा तो हाई रिस्क ऑफ हाइपोग्लाइसीमिया नहीं होगा. कंप्लायंस कैन बी हाई. यस, एक बार लगा लिया, स्लो इन्फ्यूजन हो रहा है डिपेंडिंग ऑन द रिक्वायरमेंट. तो आपने मान लिया लगा दिया कि आपको अगले दिन में 20 यूनिट चाहिए, तो आपने फीड कर दिया तो 20 यूनिट्स को वो डिवाइड कर लेगा किस समय पे आपको आपकी बॉडी में रिक्वायरमेंट हो रही है, उसके अकॉर्डिंग वो स्लोली एंड स्लोली वो जाता रहेगा. तो देयर विल बी लेसर रिस्क ऑफ हाइपोग्लाइसीमिया. इट कैन बी एक्सपेंसिव, यस, थोड़ा एक्सपेंसिव तो है ऑफकोर्स, ठीक है. द शोन इमेज इज यूज फॉर डिलीवरिंग दिस ड्रग, है ना, ओ के शेप में है ना, तो इसका नाम होता है ऑक्यूसर्ट. It is mainly for delivering your pilocarpine that happens to be one of the M3 agonist and it will be utilized for the management of the glaucoma. ये glaucoma में इसको देते हैं, glaucoma को manage करने के लिए we are going to use this one. Okay. Now this is a newer route of newer drug delivery system where the patient himself or herself can choose the amount of drug they want or whenever they want, right? Let's say a terminally ill patient that they have, the shown image can be used to deliver this drug. General anesthetic, तो general anesthetic patient तो decide नहीं करेगा, again this will be decided by the patient और patient खुद अपने आप से ले सकता है. Inhalational anesthetic, again it will not be decided by the patient, it will be the anesthetist. Rotahellar bronchodilator, rotahellar तो ऑफकोर्स ये हो नहीं सकता because rotahellar का इमेज अगर आपने देखा है तो you will never forget. Rotahellar will be something like this. rotahellar ऐसे कुछ रहेगा, है ना, उसमें यहाँ कैप्सूल डालने का जगह रहेगा. एंड दिस विल बी समथिंग कॉल्ड योर माउथ पीस. दिस विल बी योर रोटाहेलर वेयर यू कैन कीप द ड्रग हियर, और यहाँ से ये माउथ पीस होगा. तो ये रोटाहेलर तो है नहीं. रोटाहेलर इज मेनली यूटिलाइज फॉर डिलीवरिंग योर ब्रोंकोडाइलेटर्स और स्टेरॉइड्स, है ना, इन आस्थमा और COPD. सो दिस इज डेफिनेटली फॉर डिलीवरिंग मॉर्फिन, है ना. सो एज एंड व्हेन रिक्वायर्ड फॉर द क्रोनिक और टर्मिनली इल पेशेंट दे कैन टेक द ओपियोइड, है ना. A patient of Parkinson developed this shown condition after treatment, the drug which can cause this one. So what is this condition called? This condition here is known as your libido reticularis. This condition is libido reticularis, that is always and always associated with which one? COMT inhibitor, MAO-B inhibitor, dopamine receptor agonist और NMDA blocker. थोड़ा सा ट्रिकी है पर बताइए. The name of the drug that can cause this one will be your amantadine. नहीं, amantadine, what is the exact mechanism of action we don't know, but amantadine has shown to have some effect, like they can promote the dopamine release, inhibit the dopamine reuptake, and they also have NMDA blocking property, है ना. Increase the dopamine release and they also going to inhibit the dopamine का reuptake. They are going to inhibit the dopamine ka reuptake and they also have NMDA blocking property. So D is the correct answer. I think same question. Remember, always remember our skin that we have. Skin has absence of an enzyme. Absence of an enzyme. Is it elastase, synthase, hydrolase और caspase? Caspase तो यार ये apoptosis में पढ़ते हैं ना आप लोग, पैथो में पढ़ते हैं, आपका favorite subject है ना. But there is going to be absence of hydrolase. Hydrolase is actually the enzyme that is causing breakdown of the drug called bleomycin. So whenever you look at the bleomycin is actually metabolized by the enzyme known as your hydrolase, which is abundantly present in the liver. It is abundantly also present in the spleen. ये यहाँ पे metabolize हो जाता है. It will be metabolized, but it will be absence of hydrolase in the skin. There will be an increase in the accumulation. Right, skin में absent होगा, so there will be accumulation of this drug and they can lead to your flagellate dermatitis. So the name of the answer will be hydrolase enzyme. One of the phosphodiesterase inhibitor that is recently approved for the shown condition: roflumilast, apremilast, ambrinon, inoximon. Tell me please, all of you, those who are listening to me carefully. So what is this condition? If you see, there is a nail condition you can see, or silver patchy skin. I think ये खुद अपने आप में कई सारी बातें बोल रहा है ये ड्रग. It is telling a lot of information in itself. पहले इसका डायग्नोसिस बताइए, देन आप आराम से बता पाएंगे. What's the diagnosis? Psoriasis, right? The diagnosis here is psoriasis. As I said, silver patchy skin, silver scaly lesion, right? and the name of a drug that is approved for this condition recently that is approved is known as your apremilast. Roflumilast is also one of the phosphodiesterase 4 inhibitor. This is mainly utilized in the management of the COPD bronchial asthma. Ambrinon, milrinon, it's one of the phosphodiesterase 3 inhibitor. They are mainly utilized in a patient with the chronic congestive heart failure. Inoximon also, right? So chronic congestive heart failure. Let me just give you a quick idea. Phosphodiesterase 3 inhibitor, ambrinon, milrinon, levosimendan, they are mainly utilized in a patient with the chronic congestive heart failure. Apremilast, roflumilast. Now what is apremilast, roflumilast? These are the phosphodiesterase 4 inhibitor and दोनों के अलग अलग uses हैं which I have told you already. Phosphodiesterase 5, these are the drug of choice in a patient with the erectile dysfunction and they can also be utilized in a patient with the pulmonary hypertension. ठीक है, pulmonary hypertension, right? So all of you guys have seen it already here that roflumilast that we have, it can be utilized in COPD. It can also be utilized in bronchial asthma, but apremilast that we have, it can be utilized mainly in the psoriasis. ठीक है, anti-inflammatory drug. I think ये question मैं already करा चुका हूँ gum hypertrophy वाला. Now this information also I have given you. Which ATT drug can cause the shown effect? So you can see there is a normal QT interval and then there is a prolongation of the QT interval in the second image. So a known arrhythmic patient on prophylactic therapy of arrhythmia was started on an ATT, second line ATT, that is anti-tubercular therapy drug. You were told to keep a check over the ECG changes. Few weeks after ECG changes were noted as shown. So there is some increment in the QT interval prolongation. Which of the following drug can cause that QT interval prolongation? So he is a arrhythmic patient as well. Anti-arrhythmic पे भी है और ATT, bedaquiline, amiodarone, pretomanid, all of the above. So all of you guys should know that QT interval prolongation in the anti-arrhythmic drug class 1A and class 3 can cause because they both have potassium channel blocking. In the TB we have bedaquiline and pretomanid, they both can cause. So correct answer for this one will be your all of the above. All of the above. Class 1A anti-arrhythmic drug, bedaquiline, pretomanid, delamanid, they all can cause QT interval prolongation, right? So this will be everything which I wanted to discuss with all of you guys in our today's session, and we have covered good amount of question here. Most of the teratogenic area we have covered, सारे graph हमने cover कर लिए, area under curve, Tmax, Cmax, all we have covered, potency, efficacy we have covered, teratogenic effect we have covered, right? I hope you guys have enjoyed this session, and I'll be conducting more YouTube session for all of you guys on the platform. If you guys have any specific need, any specific topic that you wanted to study, definitely you can message me and we can meet again on the same platform here, right? There is no comprehensive, but there is gonna be a crash course that is going to start from 16. So if you guys are looking for a 10 hour में कोई फार्मा को ऐसा ब्रशअप कराए कि 10 घंटे में हमको 20 नंबर आ जाएं, तो आई एम नॉट प्रॉमिसिंग कि नहीं 20 ही आएंगे. इट कैन बी लेस, इट कैन बी मोर, बट ऑन द बेसिस ऑफ द पास्ट एक्सपीरियंसेस वी हैव गॉट गुड अमाउंट ऑफ क्वेश्चंस दैट वी कैटर इन आवर क्रैश कोर्सेज. सो दैट इज गोइंग टू स्टार्ट वेरी सून. 10 hours का क्रैश कोर्स है. इफ यू गाइज आर फ्री, प्लीज फील फ्री टू अटेंड दैट सेशन. इट विल बी ऑन द अनअकैडमी प्लेटफॉर्म स्टार्टिंग फ्रॉम 15 और 16 से स्टार्ट हो रहा है. आप प्लेटफॉर्म पे चेक कर लीजिएगा, एग्जैक्टली डेट मैं बता दूंगा आपको. ठीक है, चलो बाय बाय टू ऑल ऑफ यू गाइस. थैंक यू वेरी मच फॉर योर प्रेजेंस एंड अटेंडेंस. आई विल सी यू अराउंड.